Hello everybody, welcome to the exoskeleton number 2 lecture. You guys have completed the practical, so many of these structures will be more of a review for you. We will cover a few extra structures compared to the lab. And do me a favor, whatever you studied for the practical, don't actively shake it out of your mind. Keep them in your memory banks. Your lecture exam 3 will need all that, including what you see in today's lecture. So I tried to bring in as many clinical illustrations and examples. So this is going to be a little bit more than just going through the bony structures. And we didn't see this view of the vertebral column, the anterior view showing the stacked bodies on top of each other. This is a great way to show that the body portion of the vertebra is carrying the load because of this tight packing, and we're not saying anything new regarding the numbers and the regions. 7 cervical vertebrae, we have 12 vertebrae in the thoracic, 5 in the lumbar, 5 in the sacral, and 4 in the coccygeal region. We do say a little more about the intervertebral discs. This is going to show up in our joint chapter as well. You may have seen this in the practical, but in the practical material, we just mentioned this as a cartilaginous joint. In the tissue chapter, we mentioned this as a prime example of the fibrocartilage tissue type. So here it is now in its functional sense, placed in between the vertebrae. The intervertebral discs, which is softer than bone, helps to absorb some of the impact, standing, walking, and just everyday movement. The impact can be absorbed because of the watery nature of the fibrocartilage, and by the end of the day, the constant force absorption and the force of the gravity will squeeze this intervertebral disc into a much thinner disc. So if you measure your height, you are a quarter, maybe half-inch taller when you wake up, because during the nighttime, all your intervertebral discs have reabsorbed water, became thicker, and at the end of the day, the water loss will thin out the intervertebral discs. This is a great way to view the intervertebral foramen. We'll come back to this a number of times. With the intervertebral discs, there are a number of clinical malformations that are possible, clinical issues, and one is the slipped disc or herniated disc. So herniated disc means that a portion of this intervertebral disc, which is supposed to be sort of circular in nature, a portion of this disc becomes weak, whether it's because wear and tear, whether some kind of a huge impact, something caused damage to the tissue, and some of the cells of our immune system may have come here and degraded part of that tissue debris, and that opens the way for a weakening. If you remember, fibrocartilage with all those resident chondrocytes have very poor nutrient supply because there are no blood vessels in this tissue. So repair, self-repair is not possible. So the continuous wear and tear eventually may push this thinner aspect of the disc posteriorly, and here we see the spinal cord getting pushed on, and also the spinal nerve. Our nervous system reacts with a decreased function when it's under physical pressure, and this is true for collection of fluids on the brain, whether it's blood or whether it's tissue fluid. It is true for example, when you hit your funny bone, you actually impact your ulnar nerve, and that's why you get that tingling feeling in your ring finger and pinky finger. So our nervous system will react negatively to something like this. The effect of a herniated slip disc is that fewer nerve impulses will be rushing through the spinal cord. Fewer nerve impulses will be passing through the spinal nerve. And you might say, well, who cares? I'm going to pass, instead of 1,000 nerve impulses per second, now we're going to pass only 500. This becomes important when you know that the skeletal muscles operate on nerve impulse signals coming from our central nervous system. So muscle weakness may develop, maybe total immobilization of the muscles result. And so weakness on one side or immobilization on one side may be the outcome of slipped disc. So in addition to this artist rendition, let's take a look at an actual MRI. So here is our vertebral column, several recognizable features. You can see the spinous processes here. So this is the back side of this person. You see the bodies stacked on top of each other. This is the lumbar region. Here you see the sacral promontory, this little tip of the first sacral vertebra. So, and you can see the discs. Now, some of them are a little malformed, but this is the big issue right here, below lumbar 5. You can see that this disc material is now pushing on the spinal cord. So this is when pressure is going to degrade the function of the central nervous system. We don't see the spinal nerves here, but it's not impossible that they are being impacted. So it doesn't look like much, but it doesn't take much to influence our nervous system. As you'll see, in AMP1, especially when we get to the nervous system, and AMP2, you'll see number of times that our nervous system reacts first to things like oxygen deprivation, deprivation of nutrients such as low blood glucose, hypoglycemia. Here is the MRI image of a slip disc, again negatively impacting our central nervous system. On the previous slide, you said one way to deal with this is surgery. Sometimes there are injectable treatments, first to relieve inflammation, steroids, cortisol might be injected here. Also, there are other ways to trim back this piece of intervertebral disc. The point in all those treatments is to relieve the pressure on the spinal cord. We didn't talk about this aspect of the vertebral column in lab whatsoever. And these are the normal curves. We didn't have a really good look at a skeleton. In a face-to-face lab, you would see this every time you're in a lab. You would be shaking hands with them 3 hours in every lab. So this is the normal curvatures from the lateral view of the vertebral column. When you saw the anterior view, you saw that the vertebral column was totally straight. So anterior and posteriorly directed curves are okay. I'll show in an X-ray in a few minutes when we saw that the lateral curvatures are not so good, not so normal. So we have primary and secondary curves. The primary normal curves form during fetal development. And why would the thoracic in light blue and sacral in green would develop a curvature in our fetal days. We can't just say that while the fetus is kind of curved up in the womb, why doesn't the cervical or the lumbar develops any of these curvatures? So the answer to this question is that large bony structures are developing near the thoracic vertebrae, namely the ribs. You know very well that each thoracic vertebra has a pair of ribs attached to them, and the physical development of those ribs create the curvature in just a different environment. For the sacrum, you know this just as well. The sacral, next to the sacrum, or the sacral vertebrae in this case, a huge bone, the coxal bones, are developing. So that environment changes the neighborhood of the sacral vertebrae, and they develop a slight curve. The final curves that include the curvature of the cervical and the lumbar regions come about within a year or two after birth. The first one is happening within 4 to 6 months. This infant is experimenting with muscles, gaining muscle strength, try to balance the head. So as we would say in AMP, this infant is trying to balance the occipital condyles on top of the atlas, right? That's what, it's a very slippery surface. It takes a lot of muscle force and coordination. But once this infant is maintaining a balanced position of the head, the weight of the head is now pushing down on the cervical region, creating this curvature that is sort of counterbalanced and stabilized by muscles and ligaments here. And when the toddler starts to walk, gradually a lumbar curvature develops. This is because now the entire weight of the, well, almost the entire body, head, neck, shoulder, upper arms, abdominal, and some of the thoracic cavity weight is now supported by the lumbar vertebrae, and in combination with local muscles, this force brings about the lumbar curvature. This is a not so normal curvature. This is now curving to the side, lateral curve. This is an X-ray of a scoliosis patient, and to convince yourself that we're looking at lateral directions of the curve, you can see the clavicles here, you can see the ribs, and you can see some manipulation here. Looks like some stabilizing, maybe a pin was placed, maybe here too, along the spine. So this is an abnormal curvature. Why would something like this develop? A lot of the times, muscle weakness on one side causes the abnormal pulling forces that create scoliosis, and that muscle weakness can come from some kind of a muscular dystrophy affecting one side of the body, causing muscle weakness, or some other type of developmental abnormality. We will say, just like in the lab, a few words about the generic or typical vertebra, and we are not saying anything new here. We mentioned the weight-bearing portion, the body. You've seen that a number of times, whether in that MRI or artist rendition, when the entire vertebral column was in front of us. When we stack these bodies on top of each other, we create a weight-bearing structure. From the body, outgrow the pedicles, these little legs of the vertebral arch, and the lamina tops off this arch. When we talk about spina bifida, we'll mention that this portion of the vertebra in some of the sacral vertebrae are missing in that disorder. And of course, we see this naturally missing on a sacral 5 when we see the sacral hiatus. But on most vertebrae, we do have a vertebral arch, and of course the transverse processes and the spinous processes grow out to serve as muscle attachment sites. Can't forget about the vertebral foramen protecting our spinal cord. The intervertebral foramina showing up here again, and we'll be seeing these openings in a few times where spinal nerves are exiting here. And the intervertebral foramen is formed by the stacking of two vertebrae on top of each other. So you need at least two vertebrae to form a intervertebral foramen. This is a model view. So this is the lumbar region, the intervertebral foramina a little larger, and we see a spinal nerve coming out. So you can see the spinal cord in the vertebral foramen here. So this is just to show what kind of an engineering feat the body does when we create a vertebral column. We have this superhighway of nerve impulses in the form of the spinal cord, but then we have to send nerve impulses laterally. So how do we provide a bony vertebral canal but still provide openings on it to the side? So this is how our body solves this engineering challenge and creates the intervertebral foramina between two neighboring vertebrae to allow spinal nerves to exit. In terms of the cervical region, we will mention here, although they are not labeled on this illustration, but the biggest hallmark of a typical cervical vertebra is the transverse foramen right here on the transverse process. Of course, in terms of recognizing it, a body that is smaller than the vertebral foramen is also a good way to look at that. Of course, we have to mention here atlas and axis, the first cervical vertebra, and here are the superior articulating facets that make contact with the occipital condyle, allowing the yes type of movement of the head. And of course, we have axis, which has this odontoid process, also called dens, that protrudes into the atlas and serves as a pivoting point. And rotating of the atlas left or right around the dens allows our head to carry out this no type of movement. I wanted to show you that world famous intervertebral foramina in the cervical region. So here's the vertebral artery we mentioned in the lab, and it was on one of the previous slides as well. So this is what the vertebral artery looks like. Really weird, because inferior to the cervical region, the artery is running free, but after that it is enclosed in the transverse foramina of all 7 cervical vertebrae. And a major supplier of our brain is the internal carotid artery, which is a branch of this that goes through temporal bone. We've seen that in a previous lecture. And here's a backup, a posterior blood supply going to our brain. And you can see this incredible curving, coursing of these arteries. And right here is where these arteries enter into the cranial cavity. For the thoracic region, we emphasize the presence of ribs, and we'll have a separate section on them. Here, this is a good illustration. Unfortunately, this is the best artistic rendition. Even in a face-to-face lab, we couldn't see them. The articulation points on the transverse process for the ribs, and also one for the body. And I believe it will be the very last slide that has an enlarged version of this. So attachment of the ribs and the presence of those articulating facets is a hallmark of the thoracic vertebrae. Of course, you see here too the shield or heart-shaped body, which is also a good way to recognize these. For the lumbar vertebrae, we see a kidney-shaped, very, very large body, carries most of the weight, so it has to be really strong. And the spinous and the transverse processes are very strong, thick, because very strong muscles of our lower back will be attaching there. With regards to the sacrum, we'll mention maybe a couple of new things here compared to the lab. But let's start with the statement that 5 sacral vertebrae fuse together by age 30. And the fusion of these vertebrae create sacral foramina. These are the intervertebral foramina on the sacrum. The fusion of the vertebral foramen creates the sacral canal. Here's this world-famous sacral hiatus, where the spinous process of the sacral 5 vertebra is missing. And fusion of the spinous processes, of the 4 spinous processes, create the median sacral crest. And the fusion of the transverse processes create the sacral ala. At this angle, it's not tremendously visible, this auricular surface where the coxal bone articulates here. Interestingly, it is in the appendicular skeleton lecture where we take a look at the area called the pelvis. That's because the coxal bone is part of that structure, which is part of the appendicular skeleton, but that's the part where we see a good example of how coxal bone is joining the sacrum. This is an image of a spina bifida patient. So what is happening in this spina bifida patient? The vertebrae, not only sacral 5, but sacral 4, 3, 2, sometimes even vertebrae superior to that, have no spinous process, no pedicle, no vertebral arch. So in a spina bifida patient, this area here is just as open as the sacral hiatus. In some patients, rarely, this abnormality of missing vertebral arch appears in the cervical region, sometimes all the way through the sacral and lumbar region. So spina bifida has a number of severity degrees to it. Nonetheless, you can kind of see the danger of exposing the spinal cord by having a very short, or in some patients, absolutely no sacral canal. and sometimes a inflated skin forms over this malformation. Sometimes it's totally raw, totally open. So spina bifida is the abnormality of most of the time sacral vertebra formation. This slide is titled the coccyx. All we're going to say about the coccyx, and we've said this before, the fusion of 4 coccygeal vertebrae, but the coccyx, together with the inferior aspect of the sacrum, provide us with bony landmarks. And these are these bumps called cornu. And these bumps are a great landmark to palpate where the sacral hiatus is. Now, why would anybody want to know that? So here is the sacral hiatus. It's an artistic rendition, not super accurate, but it does tell you that sacral hiatus provides an access way for injections into this space, into the sacral canal. So we see the spinal nerves. Well, we don't want to inject into a spinal nerve. The aim for either anesthetic or anti-inflammatory injections, the aim is a connective tissue which fills the epidural space. Our spinal cord is wrapped into the meninges, and outside of that meninges, between the meninges and the vertebral foramina, or here the wall of the sacral canal, there's this adipose tissue, connective tissue rich layer called epidural space. And that is the target. Once an anesthetic is injected into this epidural space, we avoid injuring the spinal cord, but yet provide a way to administer those agents. From the epidural space, by diffusion, those active ingredients will reach the spinal cord, and whether they're fighting inflammation or providing anesthesia, we can reach the target of the spinal cord without actually injecting something into it. So those bumps, those cornu of the coccyx and around the sacral hiatus provides a great bony landmark, so one can carry out this injection. We're not going to say a whole lot about the thorax area. We didn't even call it this, we just called it the sternum and the ribs. So as a function, we see the protection emphasized here and provide support for the bones of the shoulder girdle, the pectoral girdle, which is scapula and clavicle. But then there is an additional function for this thoracic cage. When you look at this, the function is not obvious. This will come to us through the respiratory system. With every inhalation, we have to elevate the ribs to increase the volume of the thoracic cavity. Now we're going to have that muscle diaphragm to help us, but all these muscles, diaphragm and the external intercostals, attach to the ribs. The diaphragm's attachment points are the xiphoid process and the cartilage portion of the ribs. So we do need this assembly of skeletal structures to provide attachment sites for muscles of respiration. If we disable the diaphragm and the external intercostals, we no longer have inhalation. And that's pretty much the same as if you just decide to hold your breath. We can't go on very long with that. So in addition to protecting the heart and lungs and the kidneys, the ribs and the sternum is great, but it's even more important to provide attachment sites for muscles of respiration. Nothing new on this slide. Manubrium, body, and xiphoid process are the three parts of the sternum. With the ribs, we're also not going to say too many new things. And besides those three classes of ribs, the true, false, and floating ribs, this is the closing image. Just how are those ribs articulating with the vertebrae? So here we have a ferrotypical thoracic vertebra. On the left, you can see the articulating facets for ribs. And the ribs have a head portion with a hyaline cartilage layer on it, and also have a bump or tubercle on the rib with yet another hyaline cartilage layer on it. The articulating facets have a hyaline cartilage layer, and if we would dissect this area of the body, we would see an articular capsule around both rib articulation site. And that means that if you reflect back to chapter 4, the tissue chapter, where we talked about the synovial membrane, we have a lubricated joint for the ribs. And here again, there's just one explanation why would our body pay so close attention not only to put hyaline cartilage here at these points, but to provide an articulating capsule and synovial membrane to lubricate. With every inhalation, our ribs are moving in these articulating sites. So inhalation, function of the respiratory system is helped by providing this fairly complicated attachment site for the ribs. So this is it for the Appendicular Skeleton 2 lecture. Please don't forget that there is a chapter quiz opening on chapter 7, and I know this is right after the practical. Hopefully you guys will have plenty of experience, plenty of preparation from that left from that practical to do well on that chapter quiz, and again to retain this material for lecture exam 3. So I'm going to say goodbye, and I'll see you guys in lecture on Wednesday when we'll talk about the appendicular skeleton.